Kelly's going to be recording for us. Thank you.
Fabulous. Thank you, Kelly. So that's all started. Great. So welcome. Apologies from Wendy. We assume Jonathan as well. Any more apologies? Nope. Okay. Any declarations of interest relating to the agenda other than the usual GPs? None. Okay, fabulous. So quickly into the minutes of the meeting that was held on the two to approve. One is the 7th of September, which Bev kindly chaired. Any comments on those meetings? Minutes. All happy to approve. I won't go through page by page because they were redacted in certain places for certain individuals. So that's fine. And the minutes of the 5th of October, everyone happy with? Stunned silence, marvellous. And there were no matters arising from the 7th of October. I think, therefore, unless anyone has any outstanding actions, I can't see any actions that are outstanding from the public meeting. So everyone happy to go straight into Julie now, not Kieran, on primary care delegation verbal update for item 5, please. And you're on mute, Julie.
Yeah, apologies, sorry. I'm just getting to, so item 5, bear with me. I think I've got the wrong papers. I can't have. So,
it's my fault. I was reading the wrong agenda.
No, you're doing Chair's update. It's item 5. Sorry, you confused me there, Andrew. Do you want to do that?
Chair's update. No, nothing to update. Everything is on the agenda. So we'll go straight into item 6 with which is the GMAST update, please. Sorry about that.
That's all right. No problem at all. Okay. So as ever, I'll take the papers as read. So you'll see from the update report that there were 3 contract variations completed last month. The long COVID DES, we've now got 60 out of 68 practices who've signed up for that contract. And then the other point to notice is that we, in line with the contract, we have extended the DPO service, which we as a CCG are required to provide for all our member practices, and we have extended that as per the detail in the paper. So happy to take any questions.
Thank you. Jo.
So it's more just a general question, and I'm not going to say this about every paper, but just really wanted to look at some of these things from a transition point of view. So particularly the DPO, making sure that those are captured, and as we go through these things, obviously most of these things are going to be on the overall sheet, but just in case there are these little areas that could cause enormous distress and difficulty, particularly with some of the online access things that are developing this month, I just wanted to make sure that those are being captured and fed into the transition process.
Thank you. Yeah, duly noted.
We're getting nods, and that will come up as a question, I'm sure, under the IT update as well. Good. Okay. So mass vaccination update. Again, Kieran's name's against this. I'm sorry, Julie.
It is. No, that's fine. So the headlines are, and I just got that, for our county overall, we've vaccinated just over 1 million patients, and that's a combination of all first, second and booster. In primary care, that means it's around about 600,000 vaccinations. And we're currently looking at the signing up of the 12 to 15 categories, and that's in process at the moment. Andrew, I've invited Donna and Sam to join for the next item, so I've just texted them to join, just to let you know. And so the other update is obviously there is the booster programme for the care homes. We are a little bit behind in some of the areas, and we're doing a bit of a deep dive to try and see what the issues, but I mean the programme is continuing as it is elsewhere. Happy to take any questions.
Okay, questions and comments, please. Stunned silence. Naomi.
more of a comment really to acknowledge the huge amount of work that's gone into the vaccination programme for everybody across the system, and particularly primary care when they're in a position where we're facing unprecedented demand and catch up from COVID and backlogs and everything else. That we continue to deliver this is a real achievement. So I'd like that just to be noted, and our thanks to everybody who's been involved in it. It's been an amazing achievement all round.
Thank you. Jo.
And while we're on the celebratory system coordination, it's probably worth also mentioning the third dose primaries for the people who are immunosuppressed. And that's something that is there's been a coordination between primary and secondary care with provision of the letters to allow people to go to a variety of different venues. So we've got an extremely complicated vaccination regime. We've got some really good coordination between primary and secondary care in producing information that makes it much easier for people who are at much higher risk of being admitted to hospital for being admitted. So I think it's a really good piece of coordinated work, but is fiendishly complicated, and worth recognising that this is a vaccination programme that changes extremely rapidly, and I suspect will continue to do so. But people are working really well together, and that's very much been a local initiative, which I think is helping hugely.
Thank you. Sharon.
It was really just to go on from there, in that I've just been on a meeting with the care homes team in relation to care home staff and the exemptions in relation to medical exemptions for care home staff. And I believe that there is a process that's been put in place with an MDT at NGH to oversee those medical exemptions. So I understand there's a cascade out of the clinical directors meeting last week, but I'm making sure with our internal comms team that information does get out to GP practices as soon as possible to help support them in this complicated world of care home staff getting their vaccines, and also where there are legitimate medical exemptions coming forward. So hopefully that will help support GPs in that difficult position.
Great, thank you. Jo.
Sorry to dive back in. With regard to exemptions, practices will now be starting to get the forms that patients are printing off the internet with their perceived reasons for exemptions. So it's worth just flagging up to practices that those are starting to come through. The majority of those are not exemptions, but obviously that may create some tension and some complaints. I believe there is no right of reply for patients who have had their application for exemption declined, but those are starting to come through to practices now, and some of those will be care home staff, some of those will be other people who believe that they are exempt. Most people who are exempt will have been through the high-risk vaccination clinic programme, because there are very few people who are exempt but don't require an opinion from the high-risk vaccination clinic. So very few practices will be approving exemptions without referring on.
Okay. Thank you. So one quick one from me, just from recollection, May was a very heavy time for vaccinations. So I'm anticipating that over the next sort of 3 or 4 weeks, we're going to have a massive influx in terms of volume of people being able to book their booster jab. Are we, notwithstanding all the efforts that are going in, are we going to be ready, or are we going to see pressure put on practices, and more importantly, that will add into pressure being put on reception staff, etc., within the local vaccination sites? Jo.
So I'm sort of putting my clinical reference group vaccination hat on for this one. So there are a whole range of different providers that are now in the market that were not there 6 months ago, in particular the community pharmacies, many of whom have absolutely ramped up their capabilities. Those are being advertised on the council websites. A lot of those are actually available for walk-ins as well as pre-bookable on the national booking service. So there are additional services. Obviously, where that's taking place in a local vaccination service, we need to be mindful of the pressures, but there are a lot more options, and in particular the pharmacies are quite different. And it's also worth being aware that the modelling of who is eligible for the boosters has been done by the vaccination service, so we are aware of that peak, aware of how many people become eligible and how many people take up the offer, and it's being cut every which way to work out and to anticipate the demand that's there. So it's actually pretty good for the older age groups, but it's going to become more challenging as we move down. I think the pharmacies are going to be really helpful alongside all of the other venues that are really, really important and working really hard. Thank you.
Thank you. Sanjay?
Just picking up on your point earlier, Andrew, primary care are getting bombarded a bit with our reception inquiries. There is comms going out. The queries range from are people eligible to when did I have my second dose, so they can work out when they had that. So we are trying that. There is going to be a staggered booster program, and the reason is primarily on people being able to get it, because as COVID rates are going up, according to the guidance, once you've had a COVID positive test, you have to wait 28 days before you can get the booster. Now, as the rates go up, you can see it's going to drag. The problem is that will drag into December, January, but it's fine. You know, it'll happen when it'll happen. But I think the options for the public are, as Joe said, massive in this county. When you go on the options menu, both through national booking and local vaccination sites, so it's huge. And in fact, people are picking according to convenience now, which is really good, both timings and location. So
good.
And they're coming into the county as well. Sorry for interrupting. They're coming into the county from outside. So I think that's the other thing, that from a risk point of view, there is a possibility that our services may be used more by people who are out of the county, and certainly anecdotally, we're providing a much better offer than some of the surrounding counties. So I'll be quiet now.
Great. And there's a part B to the question, which is around supplies of vaccine. Any concerns or issues there?
So if I come in, I think in terms of the vaccine, there is. I'm not hearing of any restrictions on it. So I think there is something about using what supplies we've got to the maximum. I mean, Sandra's going to drop in. I know that they were looking at using the use of Moderna to use that up, but there aren't any issues that we're aware of. But I think just recognising that, you know, we will that they're planning for every eventuality, but at the moment I'm not certainly not hearing anything. Unless Sanjay, you're closer to it.
no, I mean the recommended booster is Pfizer, and from what we're hearing, the stocks are adequate. Also, because we're now on a pull model as opposed to a push model, which it was before, means that the planning and scheduling is much more slicker, and the fact you can store it in your own fridge for 31 days as opposed to 4 days, which was the issue before. So a lot has changed over the last 6 months, probably when we were talking about the first and second doses, which means that operationally at whichever site is delivering it, pharmacy, Massvax, it means that things can be controlled and clinics put on in a much better way to optimize the uptake. And I think that's what's being mirrored across all sites at the moment.
Great, thank you. And finally, Toby.
Yeah, thanks, Andrew. Just two quick things to add on this. I think Sanjay and Joe's points about the number of different locations that are delivering the programme this time around does mean, from a public point of view, it is quite confusing what you do and where you go and when. So the Local Resilience Forum, which is the multi-agency partnership locally with the councils and police and fire and everyone else, which had stood a lot of its arrangements down over the last few months, that re-met again about a week ago, mainly just to focus on how can we coordinate across different partners the comms messages around who's eligible and when and what are your options and where do you go. So there's a piece of work that's being remobilised there in terms of kind of getting that comms cell back together again, but not from an overall COVID point of view, much more specifically about trying to make it as straightforward as possible, because that worked really successfully last year in pushing out simple messages. And then the other point, and it's perhaps less booster and more sort of first and seconds, there is still a cohort of population within the county who've either not had any jabs, so they're ineligible, or have had their first but not their second. And I think the first but not second's 40,000 odd from memory in terms of looking at the numbers last week. And so again, the group that met last week was tasked with the question of what else can we do to try and reach out to some of those communities who've still, for whatever reason, either not responded at all or have, but only partly, and not taken up the second, not least because we know the kind of waning effect over time of it. And also, if you look at hospitalisations locally, which are running around the 100 or so mark across the two trusts, about half of those are people who haven't been second jabbed at all at this point. And so when you look at that geographically, you've got particular communities like the Eastern European community in parts of Northampton, and there you've got relatively much lower levels of overall first and second. So it was a bit of a redoubling back on moving on to boosters is great, moving on to 12 to 15-year-olds is great, but we ought to double back again. There's always going to be a level of people who choose personal choice, that's fine, but let's just make sure that there aren't people out there that we could reach out to try and bring through as well. So just those two strands, Andrew.
Thank you. So it's a very clear message. There's plenty of jabs. Encourage friends, family to have their first, second and booster. Plenty of appointments, and if in doubt, ring 119 rather than ring your surgery, I guess is the other critical position. Great, thank you. Right, item 8, GPIT updates. I'm not sure who's going to lead. Is it Donna who's going to lead on this?
Yeah, I'm happy to, Andrew.
Thank you.
Thank you for inviting myself and Sam along this afternoon. The reason there's two of us is because we do we job share. So we're a bit of a tag team, so we're both here to answer any questions. Julie asked us to pull together a regular update for this group, which detailed some of the work that had been done across Northants, and she wants it to come to this group quarterly. Now, when we were asked to do this, we thought what we would do for the first one is actually go back over the last couple of years, because Nell and the CCG have invested heavily in GP practices, in infrastructure and equipment, and obviously Nell have helped to put that out there and to support practices. And you know, we've never been busier, like yourself, like GP practices in the last year. So we thought what we would do is pull together the first report over 2 years to cover most of the major things that we've done, so you can see the improvements that have gone out there into GP practices. And that's what we've pulled together. We've separated it into four groups. I think it's infrastructure, what we did for COVID, the GP practice equipment and software that's gone into practices. And then just your BAU, your business as usual clinical systems, optimization and operational support, because even that's evolved quite a lot over the last year. And we've put quite a few new improvements in to support practices. So it's all in the report. If anyone's got any questions, then please do ask.
Fabulous. We'll open it up for questions. Sanjay.
Thanks, Donna.
Hi, Sanjay.
This question may just reflect my naivety in IT. With I noticed on page 20 of the pack, we're talking about infrastructure improvement, and one of them was about the new line upgrades. The reason for that stood out more was more and more practices, including our own, but I hear from colleagues lots more, moving to web-based or Wi-Fi based phone systems.
Yeah.
And add that to the video calling and everything else and the increased phone consultation. Is there any risk on the bandwidth? I'm probably using completely the wrong terminology. The amount of capacity in the lines to deal with all of this.
So Sanjay, I'm not technical. So I say I'm not technical. We're separated into sort of GPIT and IT, boxes and wires. But I think I can answer your question. So all of the new fibre links that have gone in recently, they have been fibre and they have been 100 meg. Now we get reports regularly that we monitor alongside our BT account manager, and if any practices are nearing that limit, so nearing the 100 meg, or some of them are still on old 20 meg lines, if any of them are hitting that, then we put in provisions to upgrade them. And the CCG have invested heavily again over the last 2 years and are about to invest again to get rid of all of the copper lines in the area. So everybody will be on fibre, there'll be more resilience, more resilient lines, and also future proofing. And to upgrade a line once it's on, say, a 50 meg or 100 meg, it's a lot easier once they're on that fibre. So they don't have to go, BT don't have to go out and install more lines. It's just a simple upgrade. So we think we've got the resilience part right and the ability to increase. It's just now a case of getting those final practices that are on it's a line that's copper to practice, but from cabinet to fibre. Yeah. I don't need to get too technical, but we are upgrading all of them.
That's perfect. Thank you.
Great. Amar.
Just a question regarding security. Obviously, a few years ago, I can't remember exactly when, but the NHS system was, in some parts, some trusts were affected with viruses, etc. I noticed in the report you mentioned about how Windows 7 has been retired in a few places, but generally security updates and that sort of stuff, is that something that is well received or well adopted and updated in the system? And are we resilient enough from a security point of view coming over the winter period when obviously we're worried about things going wrong?
Yeah, we do have a cyber team, and again, that's not my area of expertise or Sam's area of expertise, but we do have a cyber team, and we do get the care cert alerts, and any malicious activity does get highlighted, and it gets highlighted to a number of people in the organisation. So Sam and I both get those alerts as well, and obviously if anything does come in, then we do our best to cleanse the area. And patch, we obviously have regular patching as well. So your PCs are regularly patched and regularly monitored. We've got a number of tools. I don't know if Sam, if you want to come in on.
Yeah, I was just going to add to that in that we, as Donna said, we're regularly getting the patching reports through, and that we can identify if there are particular practices that perhaps aren't having their devices patched as well as we would expect, and they can be targeted. And then what we also do is ensure that we're having sort of educating practices, I guess, in making sure that they're continually running any updates. I know we all get those really annoying boxes pop up at the most inconvenient times, and it's really important to not postpone. It is really important that we do run the updates as soon as you can, because that is all allowing those security measures to be put onto the device. So we're having those conversations with the practices as much as we can, but we're also looking at it from the outside in and making sure that we're targeting the practices that perhaps aren't doing as well as we would hope. And like Donna said, that fits with the care certs as well. So if for any reason there was a device that was picked up, it's action straight away.
Fabulous. And it just in terms, go back to Joe's point around transition, as we move into ICB, are there any risks around GPIT as we go in that transition period?
Do you want to answer that, Jules?
I thought you might defer to
What
me.
do you want us to say?
Or Toby's putting his hand up, so let's let Toby come in.
I was going to come in on exactly that point, Andrew. Right. So you got the moment before my hand was there. I mean, more just about the transition piece to Joe's point about how these services. There's two things that impact here in terms of this service area, and most board members will be cited on this. In the short run, we've got the change from a Nell position in London in terms of the service offer and that moving back in-house into the London team, and the next service picking that up from a November through to end of March point. The longer term bit, though, is ICB arrangement from April next year. And there is a business case which is being submitted into NHS England literally today, following kind of a number of months of conversations between Nell, Nex and CCG colleagues around the future options for each of the individual service lines that currently sit with the CSU provider. And that's going to a national panel, I think, on the 11th of November from memory. And therefore, we're expecting in the next couple of weeks, literally, to have a clearer view to be able to come back to. Clearly, this is a really, really critical function for us and for our practices, and it's delivered by a really critical group of staff who do a great job. And so we need to get as quickly as we can. And my interest in this, Andrew, all along has been trying to get some certainty as early as we can, both for the service, for the staff and for practices, about how that arrangement will operate, certainly from April next year onwards. So I suggest actually it might be worth, Julie, noting for future agenda item with this forum to come back to that topic in particular, because I think by the next time you meet Andrew, we'll be in a position to have a more open conversation about what that's likely to look like. But as you'd expect me to say, Andrew, the critical focus here is on safeguarding the continuity of service provision through this one, something which is so important, and holding on to the great staff we've got that deliver a really good job for us on it.
Great, thank you. Any further questions or comments? Brilliant. Thank you both very much. You're welcome to stay, but you're also welcome to leave unless you have a massive interest in the finance update that Andrew's about to give us.
Always. No, thank you ever so much.
Thank you.
Thank you.
Bye.
Thanks, Donna.
Right, Andrew, over to you. Finance update P6.
Thank you. I'll take the report as read, and I'll just go through a few brief headlines, if I may. So it's a month 6 report, so it's the position at the end of H1. But we should note that with prescribing, there's always a delay in the data. So we only have 4 months prescribing data. So we estimate months 5 and month 6. Overall, we're reporting an underspend of 1.2 million, and that could increase to 1.9 million if we receive the additional income that we're expecting for the PCN additionality roles reimbursement. So in the H1 allocation, they only funded us part of the maximum allocation for the R's roles. And if we hit certain targets and we spend more than they've given us, we can claim the additional funding. So that money should follow, and that therefore will increase the underspend up to 1.9 million. Now, the majority of the underspend is purely down to investment money that hasn't so far been spent, but we've tried to protect it within the position, and so there's £2 million that's in that position as being spent, so that we can spend that in the remainder of the year. So that has to be spent by the end of March. Now, it's probably also worth noting that it's not built into the report at the moment is the H2 position. So we're still going through the process of finalising the plans for H2, but they're going to be on a very similar basis to H1, but just with a slight greater efficiency target built in. So the level of investment funding that we've had in H1 will occur again in H2. So not only will we have this slippage from H1 to spend, we'll have the new investment money for H2. So we're looking at somewhere between £6 and £7 million of investment money for primary care that can be spent in H2 on a recurrent basis. So that's obviously something that we need to progress at pace. And obviously that money is protected on a recurrent basis, so that will be available year on year. So that's really all I wanted to point out as the main points. So I don't know if there's any questions.
Thank you. Toby.
Thanks, Andrew. It's on that point, sorry, Andrew H. Andrew B, it's on the point that you were just touching on there in terms of underspend positions. I met with Stuart last night, and Julie, I don't know whether Stuart's had a chance to catch you yet this morning on this, but going through the positions yesterday, it's clear, as Andrew's just described, we've got a compound effect of underspends in different periods that is now building up around primary care. And I think we need to train a small group of folk to start doing some brainstorming in terms of thinking more laterally. There's a positive here. There is a massive opportunity for us to do something really substantially different than where we are at the moment in terms of some of our primary care, and for all the reasons we know around capacity, around stretch, around access. But to do it on our own terms using resource that we've got within the system. And from talking Andrew to Stuart yesterday, whilst there comes a point in a couple of years' time down the road where some of the other investments we've made will start to kick into recurrent positions, actually there's elements of this in quite large numbers that we could look to invest on a recurrent basis over the next few years as we go forward. And at the moment, if we're honest, I don't think, all sorts of understandable reasons of where our heads have been over the last 20 months, we don't have off-the-shelf strategic investment options to bring forwards. But what I was suggesting to Stuart yesterday is that perhaps Julie, you and he convene a session that gets a number of our kind of clinical leads, Joe, a couple of other folk, just to start really informally thinking through what's the art of the possible here. Because I suspect most people, and I saw your facial reaction, Andrew H, to that briefing on underspend position, I suspect most people haven't got that kind of scale of opportunity in their heads at the moment, but there's an opportunity here to do something really materially very different over the next couple of years. And I'd like us to do that consciously rather than just sort of drop things in to try and push money out the door before we get to the end of March, for example, which often doesn't deliver anything like the benefit that we could with that scale of investment. Thanks.
And I think I had the benefit of forewarning. Thank you. Thanks to Julie in terms of the opportunity being there. And I guess my sort of, it's that real balance between how do we address resilience within GP, across the piece with this mixture of recurrent and non-recurrent position, because you can't fix things by just throwing money without a plan and an outcome focus. So I would totally support a position. I don't want to be flippant with what is taxpayers' money, but equally I think we all know that if we have the opportunity to invest in this area, the public would be fully supportive of investing to ensure that access is as strong as it can be, that GPs are resilient and protected for the long term, and the services they provide can improve the outcomes of patients. So fully support it. Can we get something up and running quickly? And if we need to make any decisions in terms of approval of those funds, we may need to convene a meeting sooner rather than later to go through those options, which I'd be very happy to do. Any questions then for Andrew, either on the specifics of the finance update or the plan for how we might address some of this underspend? None at all. Okay, so please be receptive, especially from a GP perspective. We really need to ensure that we've got clinical input. Can I just caution that we sort of have a very single-minded view in terms of how we discuss this? Because what I think there is a danger of a message of underspend sometimes means that we haven't been focusing properly in terms of how we spent it. So I think we just need to be really clear in terms of this is an opportunity that has arisen because of where we are, that we are going to make the most of. So I think maybe Julie and team just need to have to think about how we communicate and how we sort of involve practices without setting any hairs running or setting any expectations running. Good. Okay. Any further comments? It's going to be a very quick meeting, isn't it? So we move on to item number 10, Sharon with the primary care quality report.
Good afternoon, everybody. I'll take the paper as read, but I just want to draw your eye to two elements. The first is the work that we're doing in relation to what we've called Citizen YB. So many of you are aware of the work that Gabriella and I have done in relation to promoting the Yellow Bracelet scheme for reducing admissions from care home and domiciliary care agencies into ED. And what we've done is we've looked at the same technology, but not a bracelet, using a key card to be able to, for our Afghan citizens in county to have their information gathered from their migrant health checks and their COVID vaccination status to be put in a similar way onto a key card, so that should they turn up in a GP practice or emergency service first responders go to see them very, very quickly, they'll be able to scan the QR code on that key card and be able to access key information about that individual. The other thing that it will do is, as and when they move out of county, that key card they can take with them, and for their new GP out of county, we can give them there'll be some information on how they can access the QR code to find out some key early information about any long-term conditions, any illnesses, their COVID status, etc., into that. And this is a really good news story of really taking a technology that we've won awards for in Northamptonshire and using it for a slightly different purpose. In the report, it said we were going live on the 10th of October. Sadly, our cohort at the Holiday Inn in Bedford Road were in contact with a positive COVID clinician during last week, so sadly we put them into isolation and said we would be going live this weekend. So we're ready to go this weekend to start those migrant health checks and those individuals receiving their key cards with that information. So each family member will have a key card, and we'll work with those family members to be able, for the mum or dad with 4 or 5 children, can identify which key card belongs to which person. So we'll just work through that. So that's a good news story. The Home Office are very interested in what we're doing. We're the only people in the country that they're aware of that are doing this. So we would hope that this is a very positive and good news story for Northamptonshire. The other element is around childhood IMS and vax, and you see in the report that we have got some children that have not received their vaccine, and a process that we're putting together to inform practices about children that haven't had their vaccine. We are working in the background with our childhood IMS and vax team, both at region and locally, to be able to understand why people are not coming forward for their vaccine and how we get into the hard to reach groups and actually tackle, again, Eastern European particularly communities where, not only do they not want their COVID vaccines, they tend not to want their childhood IMS and vax either. So we've got a meeting next week to start having some of those conversations about what we can do to infiltrate those areas and really get to understand why they're not coming forward and promote the childhood IMS and vax, so that we can make sure that our children in Northamptonshire are protected as well as we can we can do. So they're the two areas I really wanted to bring to your notice as work that we're doing, and I'll take any questions about anything else in the report.
Fabulous, thank you, Sharon. Any questions? No questions? Brilliant. Well, we note the report and congratulate everyone on the scheme and hope that it rolls out across the country. Okay, so we have no governance items raised. Bev, a review of risk, item 12.
Sorry, I'm just trying to get my camera to come on. I think noting the risks around the surge around vaccination is something that I made a note of, even though we've got that well mitigated in terms of, as Joe said, all the data cuts of how that's coming through. But, you know, if we did have a surge, are we able to contain that? I think the second one, which hasn't sort of come up in a pointed way here, but actually came up at Audit and Risk Committee this morning, Andrew, and it's this theme around risk around workforce availability, capacity and availability. And so, although we weren't directly talking about that in terms of the meeting, for me, that's becoming increasingly a concern that all committees need to be cognizant of. That's going into COVID, going into winter and all the rest of it, the normal staff shortage type elements, but also knowing that we've got general system pressure on workforce. So it will come through specifically, but I think, you know, every committee in the CCG needs to be mindful of that, because it does flow through.
And I think also that can flow through to the planning we were talking about with the underspend.
Yeah.
As to how that could possibly help. Okay, yeah. So I do apologise. I put you on the spot there because I think it was a hangover from the last agenda where your name was against review of risks.
Yeah, no.
So you would have said, you said what I would have said, so that's perfectly.
Well, I'm making a note for me to take back into quality, so it just shows how helpful it is to triangulate all these things, because they do, you know, they do all have interdependencies, don't they?
Yeah, and I think there is a subtle one which I think hasn't been brought out in this committee, but I think we're all very cognizant of the fact that the pressure that GPs and their staff are being put under at the moment, with some sort of quite demanding requests, both from external sources but also patients, in terms of requests for face-to-face and access. This isn't going away in terms of the pressure, so I think we just need to be really mindful of that in terms of how we can support over the coming months, because I don't think winter's going to make it any better. Okay, primary care reports are there for information. Toby, sorry.
Sorry, I just thought it was worth, Andrew, from a risk point of view, if we're capturing those things here. I didn't want to overplay it earlier on with Nell colleagues in terms of the IT item on the call, because I didn't want to make people any more anxious than they might already be around this. But I think in the round, CSU support services over the next 6 months present a level of corporate risk, less so to individual practices, although clearly the kind of GPIT side of things absolutely does. And I think, you know, I'm keen to make sure that we've got that captured from an audit and risk perspective. The short-term hosting arrangement with Next between the 1st of November and the end of March should just about stabilise things through that. But Next won't be a potential provider from April onwards of that set of services. And that's what the kind of business case is looking to address and work through. So I just thought it was worth adding to Bev's very sensible list of things there as well. Thanks.
Thank you, and thank you for picking up, because I wasn't sure with them on the line, so hence I was positioning my question around continuity. But obviously it is out in the public domain, so thank you for handling that. Joe.
Just wanted to raise another risk that's appeared in the last few days, which is the plan to give patients unrestricted access to their entire medical record prospectively from the 1st of December, which is an NHS X NHS digital initiative, having just attended a webinar on this. If that happens, there are significant risks for practices from a data controller, from a safeguarding point of view. There would be a whole host of different risks if it happens. There are consultations, but rather worryingly, the consultation dates go beyond the go live date. And for System 1 practices, the planned go live date is the 1st of December. And obviously, I'm mindful we won't have another meeting between now and then. It also has the potential that it massively increases workload, as every time you write a consultation, the patient then phones up just to check and to get the abbreviations explained as they read the consultation, even beyond the safeguarding. So I think it's something that may or may not materialise given the feedback on the webinar I've just been on, but it is in the public domain. It is going to be of public interest. It has the potential, despite the assurances I've been given, to increase practice workload, but also to increase risk in a whole host of different areas. So I think it's one that's now very much on my radar from the point of view of the burden on practices and the effect that it has on the population that we serve as well. So I'm a little nervous about the time scale and the speed and the things that have been thought through. So I thought I'd raise it here. I'm not sure whether it's the best place to raise it, but we haven't got another meeting if it does indeed go live for System 1 on 1st of December.
Okay, thank you. So one to note. Okay, is everyone happy there? Marvellous. So there was no AOB. There are some matters we need to discuss in confidence, so I suggest we end this session. Is everyone happy to take a quick comfort break and come back in come back at 3:20? Is that okay with everyone? Fabulous. So 3:20 for the private meeting. Many thanks. We can end the recording.